This is a tribute to all those who report their surgery on the SIGN database. We appreciate your reports, especially when you report follow-up until the fracture has healed. All of these segments were put together because they are recurrent themes when I review the database. I hope the information here will be shared with all SIGN surgeons in your program who do SIGN surgery, and we welcome feedback. Subtrochanteric fractures. This varus external rotation deformity is common after treatment of subtrochanteric fractures with only a nail. We looked at this carefully. In combination with SIGN surgeons, we have designed a plate which can be used to stabilize this deformity. There are many deforming factors in a subtrochanteric fracture. These include muscle forces. They include the difference in density between cancellous and cortical bone between the two fragments. And they also include the deformity caused by walking. We have therefore attempted to decrease the tension by applying a plate as a tension band. This plate is attached to the interlocking screws and extends distally past the fracture. We also found that fractures that occur below the high stress area of the femur must be stabilized better. These are very common, so we have nested the plates as a temporary measure, and now we are manufacturing longer plates with smaller apertures distally, so 3.5 screws can be used because the isthmus is narrow in this area. We also have to consider that many subtrochanteric fractures are combination fractures of subtrochanteric and intertrochanteric fractures, and therefore we use compression screws and other SIGN implants to stabilize these fractures. This is a fracture well stabilized by compression screws, plates, and SIGN nail. Not all fractures need to have a plate. Look carefully at this fracture and consider how you would immobilize the fracture. This fracture is very high, and therefore the surgeon decided not to put in the more distal of the two proximal interlocking screws. My feeling is that he could have added a plate because the fracture exits below the interlocking screw, but his results showed that a plate was not needed. We can find out the reasons and the indications for plates in addition to nails by studying our SIGN surgical database. We're still looking at many questions. When is a plate needed? What are the importance of proximal interlocking screws? Is this related to age or the configuration of the fracture? Weight bearing. When should this occur? The SIGN nail placed in infected bone. This is occurring more and more often, and we're getting good results, but I think our results could be improved. Delay from injury to wound closure and nail insertion is important, and we're looking for new methods to prevent infection in open fractures.